Thank you for inviting me to organizing meeting and Dr. Chan, Lee, so many similar names. And thank you for the chairperson, Dr. Lee, for the introduction. My name is Dong Moon from Catholic University of Korea. First, I would like to explain my hospital. This is our brand new hospital located in Seoul, Korea. This is inner complex of our hospital. Very good design and material. This is our pain center. We have 3 doctors' rooms here and here. And then we have 3 full-time pain doctors and 1 part-time pain doctor. And then 6 pain fellow and 2 pain residency. Total 12 pain doctors. And then we have 2 fluoroscopy rooms in our pain center. We have 2 ultrasound machines in our pain center and digital tomography room. We treat about 100 to 120 patients a day. Today I'm going to talk about the post-epidural neuroplasty. The content of my presentation today is going to be about 3 steps. The first one, epidural steroid injection. Second, post-epidural neuroplasty. This is called epidural adhesiolysis. And epiduroscopic neuroplasty and laser discectomy. The first one. As you know, the lumbar radicular pain can be caused by mechanical and chemical factors. Today I'm going to focus on the chemical factor. Some large discrimination cannot cause any symptoms, and sensory symptoms and size of disc not correlate with each other. This is a hernia disc. Disc can stimulate the lobe and also can stimulate lamina tunicans and sinovertebral lobe. So we have to treat all kinds of them. That is, epidural steroid cover the lobe here, and then sinovertebral lobe and lamina to treat radicular pain or radiculopathy. This is a close-up view of transperoneal graft. As you can see here, the contus media spread to the nerve loop. The important thing is to treat radicular pain, contus media and steroid have to cover all parts of the nerve loop, like this. Not this one, not this one. All parts of the nerve loop. That is very important for treatment of radicular pain. Include DRG. The red arrow indicates the sympathetic chain. The contrast media can be here. You can see the sympathetic chain. And then blue arrow indicates nerve loop. Sinovertebral lobe is around here. You can cover all of them. You can see. This patient has a big 4-5 disc herniation on left side. It can stimulate L5 and S1 nerve loop, as you can see here. We inject transperoneally between L4 and L5 and S1. But the contus media spread to here, but it cannot spread to the proximal part of L5 nerve loop. You can see the peeling defect here. This is rather good. So we did another injection here between L4 and L5 with a conventional pedicular approach. This technique. But this cannot cover this area also, proximal part of L5 area. So we adjust the needle like this, targeting Campbell's triangle, as you know, Campbell's triangle, inferior part of the nerve loop. And we finally, the contact media spread to the where we want it. That's very important. For some case, it cannot cover the transperoneal approach technique. So we use post-epidural neuroplasty. It was defined as removing epidural scarring, but it also called epidural neuroplasty because we can treat large disc herniation patient also without adhesion. So it can be called also percutaneous epidural neuropathy instead of epidural adhesion lysis. It's also called epidural neuropathy, epidural adhesion lysis, and many others. It's already presented. I'll skip this one. It was indicated for post-lumbar surgery syndrome, pelvic surgery syndrome, disc disruption, disc herniation, and spinal stenosis, radiculopathy of other origin, and pain unresponsive to spinal crossmate, and so forth. Now I am talking about the progressive epidural neuropathy. First, we have to have informed consent and explain the risk and benefit, and anticoagulant should have been withdrawn before the procedure, and we need a rapid finding. This is my set for LexCat with progressive epidural neuropathy with LexCat. You can see RS-coded needle and spring guide needle here. Catheter can be introduced to the affected side, anterior epidural space, through the anterior epidural. This is epidurogram. Normally, epidurogram should have a Christmas tree pattern like this, but there's a filling defect here. So we did some more contrast media, but still we have filling defect here. This is lateral view. Most of them are spread to the ventral area instead of proximal affected area. This is a similar patient with spinal stenosis. There is a filling defect here. So we introduce catheter to the affected area and treat them. The lysis adhesion can be treated with the use of steroid, hypertonic and local anesthetic and hyaluronidase. Currently I use 5% of hypertonic because of the complication. We cannot treat all of them. So for the lumbar area, I use Revicare instead of LexCat. This patient had L5-S1 discrimination. So pain inflammation around this area, S1 nerve root. We inject transperineal S1 nerve root, but contrast media and material cannot spread to the proximal affected area. So we did another injection here. It cannot spread easily here. So we did Revicare around here and treat them. We can sometimes introduce to the anterior area, sometimes. Sometimes use a catheter here. This is my set of Revicare. 25 years old female, have 6 months of low back pain and low pain radiating to left leg. To inject and chemical lysis like this. We use jelly, hyaluronidase, and steroid. Her pain was decreased from 7 to 2 out of 10. She can study, and she don't need any more medication and treatment. This is a foraminal view of cadaver section. You can see the disc. You can see the foramen here. This is SAP, superior articular press. This is IAP, inferior articular press. This is a ligament foramen here. This is nerve root. You can see the vessel here. This is vessel. Vessel is usually superior anterior region. For transperineal guard, this area is recommended for prevent the neural damage, inferior and posterior area. This is very important. And if you look carefully at this slide, you can see the ligament here. There is so many ligaments here. You can see transperineal ligament, superior, middle, inferior transperineal ligament, and then you can see the cochleopaper ligament here. And then interperineal ligament. This ligament can make a compartment for nerve root and vessel. In normal foraminal side, it's okay. But in case of stenosis patient, foraminal stenosis or ligamental hypertrophy case, it can cause stimulating, pressing the nerve root. That's a big problem. So we did foraminotomy. This is a cadaveric view and MRI view of foramen. You can see transperineal ligament, L-indicated transperineal ligament here and here. So we did cut this foramen, this ligament. there are various types of transperimeter ligament here. The percentage of transperimeter ligament was different from the different authors. Some also stated 100% was founded, and others 60%. The role of transperimeter ligament, it divides foramen and compartment, and then it can diminish the space of available for spinal nerve, and as a result can cause local interruption and pain. In 2011, Dr. Kwian reported transperineal ligament may play a role in lumbar nerve compression and foraminal stenosis. So we did this epidural device with Navicat, and then also we do foraminotomy. This patient is 55 years post lumbar surgery syndrome. She had severe stenosis here on the left side. This is the lateral view. We did epidural Navicat devices. S1 right, 5, 4 left, S1, 5, but we cannot place the catheter in this area. Most of them we introduce needle here and then transperineal flap together. For some cases, for difficult case, we do a foraminotomy with a special instrument. This is a new instrument. This is a needle, guide wire, guide needle, and then screw right and thread. We do like this, and then foraminotomy, ligament dissection. After that, we introduce the catheter and then inject the medication. This is the procedure. Needle transperineal first, and then guide wire insertion, and then creative here, ligamentum dissection of ligamentum. After that, catheter can cross the here, can penetrate here, like this. You can see the direct communication from outside to inside. It's very important. Like this. This is pre-treatment, this is post-treatment. Pre-treatment, he had temperature difference from 1.83. But after treatment, almost after treatment, her pain was gone, and temperature is back to normal. This is another patient of 35 years female. They have severe rheumatic herniation here, like this. She has already Navicat, neuroplasty, and transperineal flap several times for our hospital. We also cannot place the catheter this area because severe stenosis. So we did the same procedure here. And after that, we can introduce some catheter and medication. It was presented before. The PN is a superior to epidural steroid injection. In 1995, in 2005, Hamner and Cleo and other authors conclude that the evidence is pair evidence for low back pain, for post-lumbar surgery syndrome, and also pair evidence for lumbar spinal stenosis. The complication is minimal. There is no big implication. The next one. The next one is epidural radial discectomy and neurologic compression. There has been developed from medication and physical therapy to low blood, neuropathy, epiduroscopy, and now epiduroscopic radial discectomy. Epiduroscopic catheter introduced to the anterior epidural space like this, and then there's two holes here. So first of all, we introduced the fiber optic endoscope and laser here. There is two epidural space, anterior epidural space and posterior epidural space. As you know, the problem site is the anterior epidural site. So catheter have to introduce the anteriorly and treat the inflammation and herniated disc with the laser. This is our set of laser discectomy. This is a fiber optic endoscopy and so many syringes. And the pulmonary laser under the bed. First, patient face from position and head of position like this, and then we insist in the midline with 11 knife under the philosophy guidance. After that, we introduce key, roll, or carry assumption at some instrument instead of shading 50, and then make room for anterior space, a big room, and then introduce the test. We need two monitor, fluoroscopic monitor and endoscopic monitor, and we need an assistant for injection of cell line during our procedure. We can introduce anteriorly or posteriorly. To treat anteriorly to treat the discogenic problem, and posteriorly to treat the facet problem. This is a cornea average. We use this one. The test space is 2.5 watt and treatment from 5 watt to 10 watt. The advantage of this procedure, we can direct access with our naked eye, and we can diagnose and treatment. At the same time, with one procedure, we can diagnose the pain, and we can inject epidural steroid, and we can fix them. We can treat multiple levels, and neural problem, and some adhesive band or scar tissue. This is the least invasive technique, and effective and safe. This table here shows the misdiagnosed MRI for lumbar pain. Looking at the red bar, on average, the misdiagnosis of MRI for this bulging is 38% average. But protrusion 29, this extrusion 9.5. All this pathology, bulging, protrusion, extrusion, sequestration is about 60%. The MRI can be diagnosed for 60% of pain. MRI cannot diagnose pain. That is why epidoscopy is necessary for diagnosis and treatment. This is our scopic view. Yes. This is annulus tearing and bleeding here. You can see annulus. This is annulus. Turn right, please. Not right, please. It's laser, green color laser. This is a dura. Inflamed dura. This is epidural space. Epidural space is anterior epidural space here. On the right, here, this is epidural space. This is annulus. This is the dura, inflamed dura. You can see here. Raising this area, not this area. This area. Looking at the right side, you can see glittering pad. The blood goes under the glittering pad. Normal pad, under the normal pad. This is epidural space. This is annulus tearing. This is another picture of epidoscopic finding. This is dura. This is the annulus. This is epidural space. This is normal pad. You can raise it around here. This is normal pad. This is raised here. Raised. There's scarring after raising. This is epidural space here, anterior epidural space here. This is a 25-year-old female with severe disc extrusion between L4 and L5. You can see here, lateral and anterior, like this. She cannot walk well. She beat with a limping gait out pain center. So we did epidoscopic laser discectomy. And then for 2 years after that, for 2 years we treat 2 times of the transcranial graft. after 2 years after this herniation back to normal. You are not definite. It is which is due to the natural healing process or this procedure. The summary. So PEN, focus epidural neuroplasticity, technique for treatment of chronic pain, is due to the disc herniation, lumbar canal stenosis, and pelvic syndrome. In response to the temporal epidural steroid injection, and foraminotomy and epidural steroid is a new promising procedure. Thank you.